Good morning. We'll go ahead and get started since it's 8 o'clock. Morning. My name's Coco Fresh. I'm the Chief Cardiology Fellow. It's a privilege to speak with you today, along with my co-fellows, Dr. Godishala, Dr. Maher, and Dr. Tuttle. Dr. Asnani will be moderating today. So throughout the conference, if you have any questions or concerns, please use the chat function on Zoom to ask Dr. Asnani to ask these questions at the end. Also, if that's not working for you, feel free to email her. We also will be turning off others' videos than the speaker during the presentation, just to try to allow the number of participants that we plan to have today. Thank you for everyone who's joining us, both from Beth Israel as well as from other institutions. We really appreciate your participation, and we apologize in advance for any technical glitches. At this time, please take a moment to mute your microphones and/or any telephones. To set the stage, I know many of you are actively following the number of international, national, and local cases of COVID-19. Unfortunately, as of last night, we've now crossed the 1 million threshold and are over 50,000 deaths. Unfortunately, a number of these are also in the United States. In Massachusetts, you can see that our numbers are precipitously rising. This is what we've been preparing for and what we've been expecting. The number of reported deaths attributable to COVID-19 are also rising, as you can see here in red. So why do we feel like this is important to feature in Grand Rounds today? Well, as I will present, patients with pre-existing cardiovascular disease are quite vulnerable to adverse outcomes from COVID-19. My co-fellows will go on to discuss the implications of the fact that SARS-CoV-2 virus is associated with significant cardiovascular injury and mortality. Based on current epidemiologic trends and data, it's very likely that cardiologists will be involved in the care of patients with COVID-19. And the impact of this current crisis will far long last what's currently going on for many years to come for our patients and for our communities. So I must take a big pause here to stop and make a huge caveat to say that what we know about COVID-19 is rapidly changing and evolving. We are obligated to stop and make this enormous caveat because today's presentation only reflects the available publications as of yesterday, Thursday, April 2nd, and is by and large descriptive or adapted from other coronavirus experiences, such as SARS and MERS. Many of the studies we cite today are small and are unadjusted. Ever so more in cardiology, it feels really uncomfortable to act in a data-free zone. So today we will just let you know what we've seen so far. One of the first major professional societies made an announcement, the American College of Cardiology, on March 6th to tell us that there are worse outcomes for patients with cardiovascular disease. I was pretty curious where this 10.5% case fatality rate was derived from. And so in order to find that, I had to do a little bit of digging, and I found that this was extracted from a descriptive analysis of all cases in China diagnosed by February 11th. These were reported to China's Infectious Disease Information System, and it included over 72,000 patient records. And of note, these were confirmed as well as suspected. So in about 40% of the cases, these were just suspected cases of COVID-19. For the comorbid conditions, these were known for about 21,000 patients and a little over 500 deaths, and that was what was used to calculate these case fatality rates. And comorbid conditions were those that were reported by patients, and there was not a strict review of the medical records available to discover this. But as you might expect, this elevated mortality is not that unfamiliar from other coronaviruses such as SARS and MERS. Understanding the role of cardiovascular disease in COVID-19 requires reviewing the initial reports out of China. On the left-hand side, you'll see a very early report of 41 cases out of Wuhan. The majority of the patients in this study were connected to the Hunan seafood market. Of these 41 patients, roughly a third of them required ICU care. Roughly a third of these 41 patients also had comorbid conditions. The numbers are really just too small to generate any significant conclusions from this initial case report of 41 patients. On the right-hand side, you'll see a little bit later study coming out of China that was released in early February and reflected cases in January. This included a number of patients, 138, and these were all hospitalized with COVID-19, and they compared patients who required ICU care with patients who did not require ICU care. What was seen in this is that almost half of patients had comorbid conditions, 43 of whom had hypertension, 14 with diabetes, and 20 or 14.5% with cardiovascular disease. Compared with patients who did not go to the ICU, patients who required ICU care were significantly older, a mean age of 66 versus 51, and were more likely to have these underlying cardiovascular conditions, including hypertension, diabetes, and cardiovascular disease. There's also a meta-analysis that was done from some Chinese authors. They included a search that was done to look at available cases at the time, and 46,000 patients roughly were infected with COVID-19 based on these 8 studies. The most prevalent comorbid conditions, as you might expect in these patients, were hypertension, diabetes, cardiovascular disease, and respiratory disease. They did pooled odds ratios of hypertension and cardiovascular disease, for example, and they found those to be 2.36 and 3.42 respectively. Now turning to Italy. An early report out of Italy included 355 Italian patients with COVID-19 who died. I want to make a note to say that COVID-19 related deaths were defined as deaths occurring in patients who tested positive for SARS-CoV-2, independent of pre-existing diseases that may have caused their death. The mean number of pre-existing conditions in this patient population was 2.7. I'll stop to say that this is an older population, and so these numbers might seem quite high. So there are 30% of patients who are found to have ischemic heart disease, 35% with diabetes, almost a quarter with atrial fibrillation, and many with a history of stroke. So again, these high percentages reflect an older population, as well as some variable testing strategies dependent on how stringent they were at the time. And at this time, they were quite stringent, meaning that they were testing patients who had severe illness. And in this particular case, patients who had died. Now, going towards the United States, on February 28th, the Public Health Department of Seattle and King County was notified about a positive COVID-19 result from a long-term care facility. This began a case investigation, and what is reported here are the results of that case investigation by the Public Health Department. So facility residents, visitors, and healthcare personnel with confirmed COVID-19 were interviewed by telephone or proxy if they were already too sick to respond, to collect information on symptom severity, coexisting conditions, travel history, and close known contacts with COVID-19. As of March 18th, 167 patients who were connected to this facility were found to have COVID-19. Clearly, this represents a highly vulnerable aging population. They're at a very advanced age and multiple comorbid conditions. There are many limitations to this analysis, such as that not all of the individuals or workers in the facility were tested or interviewed because they only did symptomatic patients. So some asymptomatic patients or visitors who were unrecorded might have been missed. For chronic underlying conditions, no underlying condition or unknown were lumped together. So percentages represent the number of cases with information known on the coexisting condition, irrespective of missing data. Cardiac disease was present in 40.7% of all patients linked to Facility A, and this included 8% of healthcare personnel and almost 19% of visitors. Again, this mean age of this patient population was 72, so we're talking about a highly vulnerable population. Unfortunately, the reports that I have discussed this far are not stringently accounted for age, and so and other important confounders that's worth noting that have likely contributed to these outcomes. So what is the impact of underlying cardiovascular disease and myocardial injury on fatal outcomes in patients with COVID-19? This is just a preview of the next sections to come, so I'll not delve into this in significant detail here, but I would like to note that in this particular study out of China, 187 patients were hospitalized in Wuhan, and in this cohort, 35% had underlying cardiovascular disease. This was defined as including hypertension, coronary disease, and cardiomyopathy. For patients with a high troponin level, they had a significantly higher mortality. Patients with cardiovascular disease that was pre-existing, as well as high troponin, had the highest mortality. Yet it's also worth noting that patients with cardiovascular disease with a normal troponin had a lower mortality than patients without known cardiovascular disease and an elevated troponin. Although many patients were using ACE inhibitors and angiotensin receptor blockers owing to their baseline cardiovascular disease in the troponin T group, their use was not associated with the subgroup's higher mortality rate. So that brings me to the final point I've been asked to discuss today, some medication controversies. Despite the lack of evidence, there have been advocates for both the use of and the discontinuation of ACE inhibitors and angiotensin receptor blockers, or both, during the treatment of COVID-19 and in patients with just these chronic conditions felt to be at high risk. This has prompted patients to call asking to solicit changes in their antihypertensive regimen and doctors to feel some uncertainty about what to say. So our current state of knowledge includes the following. What we know is that SARS-CoV-2 uses the ACE2 receptor to enter host cells. After entering host cells, the ACE2 is further down regulated, resulting in unopposed angiotensin II accumulation. Local activation of the renin-angiotensin-aldosterone system may mediate lung injury response to viral insults. So because ACE2 receptors have strong expression in the heart, kidney, gastrointestinal system, and lung alveoli, there is some concern. In some animal models, ACE inhibitors and angiotensin receptor blockers increase tissue-specific expression of ACE2. So this worries individuals about increased susceptibility to viral host entry and propagation using that ACE2 receptor. What I will say that is not necessarily the case for the lung alveoli, and we still need additional information to test this in humans. Also, what we know is that in ARDS and infection, there seems to be a downregulation of ACE2. So actually producing more ACE2 with the ACE inhibitors and angiotensin receptor blockers may actually end up being helpful. And there have been some retrospective human studies for other coronaviruses and other respiratory illnesses that have shown that ACE inhibitors may reduce lung injury. Finally, the summer figure for ACE inhibitors and angiotensin receptor blockers, I think well explains the potential influences of SARS-CoV-2 on the balance of angiotensin II and angiotensin 1 through 7 in vasoconstriction versus vasodilation, as well as the ACE inhibitor and angiotensin receptor blocker role in increasing ACE2 in some tissues, as well as blocking the RAS activation to protect organs susceptible to injury produced by this activation. Clearly, more evidence is needed to understand this. So at this time, a number of professional societies have released statements, as you can see on the left-hand side, and the consensus is to continue these in your patients unless warranted for another reason. The last topic of medication controversy that I'll mention are NSAIDs. There is a lot of media hype about NSAIDs, and this all came from the fact that the French health minister sort of posted on Twitter that you should not take your ibuprofen, you should not take your NSAIDs because of this, in a result from a letter that was sent to the Lancet that suggested or hypothesized that this had some negative effects in causing severe illness in patients with COVID-19. The World Health Organization actually released a statement that said, please don't use these in your patients with COVID-19. And then the next day, they actually said quite the opposite. At this time, there's insufficient data regarding NSAID use in COVID-19. So what the World Health Organization said was basically like, we don't have any data to say that you shouldn't use these or that you should. So there's also conflicting evidence from past experiences. So there's a prior study of someone like 90 patients with NSAID exposures and community-acquired pneumonia that suggested that NSAID use prior to hospitalization was associated with a protracted clinical illness course and increased incidence of pleural pulmonary complications like pleural empyema. Interestingly, these patients also did not have any differences in the type of systemic inflammation nor in organ dysfunction. Also, indomethacin was studied in vitro and in animal models in SARS and found to have direct antiviral activity through interference of RNA synthesis. So you can see that there's some conflicting data. So it's reasonable to avoid treatment with NSAID in patients you otherwise normally would, but really further investigation is needed. So with that, I'll turn it over to Dr. Godishala.
Second statement that I think it's imperative that until we have more and better data, particularly from the US and Europe, we should make clinical assessments and plans both independent of and in the context of COVID-19. That is to say, our judgment and recommendations should not be completely biased by a person's COVID-19 status, ignoring the particular patient and clinical situation and evidence-based guidelines that we have at this point. So from a heart failure perspective, I wanted to point out the following uncertainties, which we hope to better characterize in the next weeks and months. As far as definitions go, presently all existing case reports and series, and I really hesitate to call them studies, they're more series, have been using a definition of troponin above the 99th percentile of the upper reference limit to define acute cardiac injury. Most of the case reports have used high sensitivity troponin assays, which we know are much more sensitive than specific. And on a daily basis, we as cardiologists grapple with the clinical significance of an elevated troponin. So it's just something to keep in mind. With the rapid proliferation of articles on COVID-19, we also need to remain cognizant of the context in which the data was collected and reported. So there's been a distinction in publications with some using troponin to define or diagnose cardiac injury, while others are seeking to use it in a predictive or prognostic way. And with regard to heart failure or cardiomyopathy, which I'll use interchangeably at this point, only one study has specified a definition of what they meant by cardiomyopathy, and they defined it as a globally decreased LV systolic function on echo, in addition to clinical signs of cardiogenic shock, elevated biomarkers, or decrease in central venous oxygen saturation less than 70% without a past history of systolic dysfunction. So that being said, the spectrum of cardiac disease appears really broad, encompassing everywhere from asymptomatic troponin elevation and other biomarker elevation to acute coronary syndrome, arrhythmia, heart failure or new cardiomyopathy, myopericarditis, and fulminant myocarditis with cardiogenic shock. And within the category of cardiomyopathy, there's a lot of debate about the underlying etiology. At this point, I'm sure that everyone in the audience has read or at least heard about the multiple case reports and series out of China of cardiac injury related to COVID-19. So just briefly going through them, on the left, Hu et al. Was the 37-year-old gentleman with a new dilated cardiomyopathy complicated by acute systolic heart failure. He was treated as a fulminant myocarditis with IV steroids and IVIG, in addition to many other experimental antiviral therapies, and he experienced myocardial recovery. In the middle was a case report of a 53-year-old woman who presented with moderately depressed systolic and diastolic function, clinically suspected myopericarditis, which was diagnosed by echo and confirmed on MRI images. She was treated acutely for cardiogenic shock, as well as with pulse IV steroids, IV aspirin, hydroxychloroquine, other antiviral therapy, And then following hemodynamic recovery, she was initiated on guideline-directed medical therapy with canrenone, which is a spironolactone analog, and bisoprolol. And on the right, Zheng et al. Described a 63-year-old gentleman who had a dilated LV and diffuse hypokinesis in the setting of ARDS and multi-organ system failure. He was also treated as a fulminant myocarditis with IV steroids, IVIG, interferon, and antivirals. This patient ultimately progressed to needing VA ECMO and sustained an improvement in cardiac function. It was able to be decannulated. And more broadly speaking, retrospective cohort analyses of Chinese data have demonstrated incidence of acute cardiac injury that have ranged anywhere from 12% to 19.7% to 28%. And sample sizes in these publications were anywhere from 41 to 416 patients. Recently, 2 case series have been published based off of US data of Washington State. On the top was a case series of 21 critically ill patients in Washington State, in which 3 out of 21 critically ill patients admitted to the ICU at Evergreen Hospital had an elevated troponin. So only 3 out of 21 that were critically ill. And 7 of these patients developed cardiomyopathy, which was defined above previously, that they gave a specific definition of. And in the case series published in the New England Journal this past week, that included 24 critically ill patients from 9 Seattle area hospitals that were admitted to the ICU with COVID-19 infection. They found troponin elevation in only 2 patients, 15% early in their ICU course, and they had performed a total of 9 echoes out of the 24 patients, and there was no new cardiac dysfunction noted. I did want to point out that there have been several case reports of isolated cardiac presentations of COVID-19 that don't have the typical systemic and respiratory symptoms. The other uncertainty that we're dealing with, and Coco went through this in detail, is patient and population risk. Pre-existing cardiovascular disease is almost certainly a risk factor, and multiple series, as described, have shown a high prevalence of underlying cardiovascular disease, particularly among patients with severe illness or death. But more speaking to the population at risk, it's been widely publicized that men appear more likely to die from COVID-19 and related disease, but these were reports out of China, and this certainly does not account for heterogeneity across different countries and populations. And the 2 case series out of Washington State did not identify the sex of the patients who died. I wanted to spend a little bit more time on the pathophysiology aspect of the heart failure and cardiotoxicity that's been seen in patients with COVID-19 related illness. And there have been multiple hypotheses put forward regarding the potential mechanisms of cardiac injury. And though there's no consensus, the likelihood is that the proposed theories that all of them contribute in some way to the different patterns of cardiac injury we see. And the main theories include, there's 4 main theories, and they include direct cardiac toxicity due to an ACE2-mediated viral entry into myocytes, resulting into dysregulation of the RAS system, what Coco was describing, a hypoxia-induced myocardial injury resulting from oxidative stress, intracellular acidosis and calcium overload, and ultimately mitochondrial damage and apoptosis. A third theory about cardiac microvascular dysfunction leading to vessel hyperpermeability and angiosperm, which Mark will talk a little bit about. And the 4th being a systemic inflammatory response syndrome / cytokine storm / catecholamine excess, resulting from an imbalanced response among subtypes of T helper cells. And regarding these possible mechanisms of cardiac injury, I just wanted to briefly highlight two articles that are awaiting publication. So in an upcoming article in Circulation, Clerkin et al. Proposed two patterns of myocardial injury, so clinical patterns. Patients that present with acute myocardial injury and dysfunction at initial presentation, which they feel is more consistent with a viral myocarditis or a stress cardiomyopathy picture, or a myocardial injury that develops as the illness severity intensifies, which to them favors a cytokine storm hypothesis. And in an interesting pre-proof JACC heart failure article entitled COVID-19 and Heart Failure, a Missing Link, Maher et al. Expands on this cytokine storm hypothesis, noting, again, in this later stage of COVID-19 illness, a hyperinflammatory state that's analogous to the cytokine release syndrome that we see with immune checkpoint inhibition and CAR T cell therapy may be manifest. And this multisystemic syndrome results in elevated cytokines, dysregulated T cells with lymphopenia, marked elevations in inflammatory markers such as CRP, IL-2, and IL-6, elevated natriuretic peptides suggesting cardiac inflammation or dysfunction, and high serum ferritin. And observations suggest a high frequency of the cardiovascular events due to arrhythmias and heart failure once these biomarkers become established. And pathologically, these manifestations are similar to a stress cardiomyopathy or cytokine-related myocardial dysfunction, and they do mimic the syndromes that have been observed with secondary HLH or macrophage activation syndrome, characterized by fulminant and fatal cytokine release. From this article, I also wanted to point out a very interesting point that the authors raise. They ask, is there a potentially overlooked cardiac contribution to the profound hypoxemic respiratory failure and the bilateral infiltrates that we see in patients with severe COVID-19 illness? Asking the question of whether or not raised filling pressures in a heart failure phenotype is also at work. As the authors state, once respiratory disease is established in the setting of COVID-19, ARDS is also accompanied by pulmonary edema that's noted in postmortem studies. And elderly patients that seem to be more susceptible with underlying cardiovascular disease and diabetes, they often have LVH, diastolic dysfunction, and even HFpEF. And so these patients may be prone to higher pulmonary vascular pressures in the typical critical care scenario of receiving significant amount of fluid resuscitation and other IV drugs. And such individuals may also receive things like NSAIDs or have acute renal failure, and their ability to handle salt and water becomes even more precarious. So the question of whether or not there's a HFpEF exacerbation on top of the ARDS. And finally, the uncertainty about treatment, and I'll just point out, namely the use of corticosteroids. At this point, reported cases of severe COVID-19 related illness that have been described in the published literature have been treated by a kitchen sink approach, variably including the use of antivirals, antimalarials, antiplatelets, anti-inflammatories like statins, immunosuppressants such as IV steroids, IVIG, and IL active agents like tocilizumab, either in isolation or more often in just random combinations. And I'll leave further discussion of treatment to my colleague, but I did want to point out that at this point, IV steroids are not currently recommended off the bat for new cardiomyopathy or myocarditis in the absence of another indication. And as we discussed on Tuesday, there are and will continue to be significant limitations to the use of IVIG, particularly with regard to inventory. So keeping in mind what our resources are. And finally, about treatment-related complications, all of these drugs listed above have the potential to have cardiac implications or toxicity. So we have to keep in mind that the treatment, not making the disease worse via the treatment. And my last statement is just about the routine use of cardiac biomarker testing in these patients. I do think there's going to be two schools of thought about using cardiac biomarkers in these patients. There's certainly an argument to be made that while we're learning more about the disease, we should probably collect as much data as possible to allow for more granular analysis long term. But I also appreciate the opinion that was expressed in a Perspective article published last week that encourages us all to be much more mindful of the implications of broad-based testing. The author states, it's no surprise that patients with severe COVID infection are more likely to have evidence of myocardial injury. The mechanisms are likely similar to that of myocardial injury and other severe respiratory illnesses and clinical scenarios in which myocardial oxygen demand is heightened and inflammation is rampant. Troponin measurements in the absence of suspicion for plaque rupture should be avoided to minimize unnecessary downstream testing. And that's just keeping in mind that we don't check troponin in outpatients with confirmed COVID-19 infection. In fact, we don't even know the true prevalence due to our lack of testing. So just keeping in mind all those limitations.
Okay, everyone, I'm going to start talking about the association between COVID and arrhythmias. So I'm attempting to take control of the screen here. Okay, so what is the association? I think many of us were alarmed to hear about the anecdotes going around out of China and Italy and Washington State about lethal arrhythmias at the end of course of the critically ill COVID patients. Here I've just pasted from an online social media post from a ICU doctor in Evergreen, Washington, describing how they were seeing their patients improve from their respiratory failure only to develop severe cardiomyopathies, develop VT, VF, asystole, PEA arrests, which I think got a lot of us concerned about the potential implications of arrhythmias and our role as cardiologists in these patients. I think it's important to remind ourselves that the plural of anecdote is not data, and so we really have to look systematically at what is going on here. So what do we know from the data? Well, the short answer is not much. There's been very little described formally in the published series about arrhythmias. One of the most cited currently is a cohort of 138 patients that were hospitalized in Wuhan, and they noted that overall 16.7% of them were noted to have an arrhythmia. They didn't define at all what they meant by arrhythmia, whether they were atrial, ventricular, whether they were bradyarrhythmias, whether they were not sustained, or whether they were sustained. So we don't really know what exactly that was getting at. They did note that there was an increase in prevalence amongst their critically ill patients in the ICU, where 44% were experiencing these arrhythmias. There are other series in the preprint literature also out of China, which have ranges of arrhythmias ranging from 2% all the way to 90%. So it's hard to know what to make of that because they also do not define exactly what they mean. More recently, from the Guo paper that Coco already mentioned from a few days ago, they did parse out that there was some VT and VF noted in these patients. So this series took 187 fatal cases of hospitalized COVID patients and found that 5.9% of them were 5.9% of them developed VT, VF greater than 30 seconds. And they did note that they were associated with elevated troponin and NT-proBNP to go along with the cardiac injury previously described. Now, it's unclear whether COVID is directly responsible for these arrhythmias, and it's unclear whether some of those concerning anecdotes were overstated. Many of the other prominent series that have been published describing cardiac injury don't mention arrhythmias at all. It's not clear whether that's because they didn't have the ability to collect that data and report it, or whether there is actually a lower incidence than previously reported. So what are some of the potential mechanisms that these patients could be developing arrhythmias? Well, I think there are many. First of all, these patients, many of them who do poorly have pre-existing cardiac conditions, as Coco mentioned, including pre-existing arrhythmia disorders. In addition, these people are developing what we believe to be either myocarditis or other types of cardiomyopathy. They're undergoing the systemic inflammatory response syndrome. They have tissue hypoxia, renal failure, increases in in catechols and changes in autonomic tone, all of which can predispose to malignant arrhythmias. They might even be developing ischemia, which we'll hear about from Mark in a little bit. Importantly, which I'm going to delve into later in this presentation, is that the drugs that we are using to empirically treat COVID-19 can also predispose to arrhythmias. That includes both the long QT-mediated mechanisms, as well as many of these patients, as they get more critically ill, are developing shock and requiring inotropes, vasopressors, and the such, all of which can predispose to arrhythmias. So getting back to this question, is COVID actually responsible for the arrhythmias described in many of those anecdotes? I think it's important to note that many people who end up in the ICU in general have cardiac comorbidities, and that the incidence of arrhythmias in a general ICU population, from MICU, SICU, all of the types of patients, is pretty common. Most of the range in the literature ranges somewhere between about 12 and 78% of critically ill patients develop some sort of arrhythmia during their time. Of course, it's very definition dependent. And a lot of the bigger series find numbers typically between 10 and 20%, most of which are atrial arrhythmias. Importantly, arrhythmias are associated with a longer length of stay and increased mortality, so it is important to keep track of them. Our COVID patients, in addition to developing cardiac injury, of course, are developing multi-system organ failure, including ARDS, sepsis, renal failure, and cytokine storm, as previously mentioned. All of those diseases are associated with arrhythmias in the critically ill population, including ARDS and the ARDSNet data. They've noted a prevalence of about 10% of atrial fibrillation that was associated with increased mortality. It was independent of their CVP, troponin, and other inflammatory markers. In sepsis, AFib is extremely common, up to 33%, 10% or so are new onset, and ventricular arrhythmias, however, are less common. Renal failure associated with multiple types of arrhythmias, and in the small literature of cytokine release syndrome, looking at arrhythmias, there are just reports of atrial fibrillation and QT prolongation. That data is significantly more limited. So what about the previous coronaviruses that caused prior epidemics or near pandemics? SARS, from the early 2000s, there was one series of 121 patients where that is commonly cited in association with arrhythmias. They said 79% had, quote, tachycardia, and about 15% had bradycardia. They don't define what that really means, and it's likely that they just included sinus tachycardia, sinus bradycardia. They noted only one patient had new onset atrial fibrillation, one patient had LV dysfunction. In another series, one patient had a cardiac arrest. However, they do not describe the exact mechanism of that cardiac arrest. Moving on to MERS in the Middle East from this past decade, in one series of 124 hospitalized patients, there was just one patient with hyperkalemia-associated ventricular tachycardia with cardiac arrest, and one patient with SVT-associated pericarditis. So what about proposed treatments? Can they also contribute to the risk of arrhythmias? Well, there's been a lot of discussion and hype around using repurposed medications in an off-label way to treat the COVID-19. These medications include the antimalarials, immunomodulators, and repurposed antiviral treatments. And I think it's important to kind of go through those and their effect on arrhythmias. So first, hydroxychloroquine and azithromycin is now commonly being used in all of our area hospitals to treat our seriously ill patients with COVID. That data is based on mostly small series in China. In addition, there was this study that came out of France last month. Only 20 patients, they took hydroxychloroquine, and some of them took azithromycin, depending on their clinical presentation, and they noted earlier viral clearance. So based on this limited data and the kind of the dire need for something to try to help these patients, it's been pretty widely adopted, including at our own institution, using hydroxychloroquine and azithromycin. In addition, repurposing HIV protease inhibitors is also being used in some patients. There was a trial of lopinavir/ritonavir after some promising data coming out of China, where they looked at 199 patients that were hospitalized and randomized them to placebo or lopinavir/ritonavir. They looked at time to clinical improvement, and they did note that there were no adverse cardiac events in this study. However, there was no real significant benefit. There was no significant difference in the patients in their time to improvement. There's maybe a little bit of a trend towards improvement. There's no change in viral clearance. So I think it's important to take a step back and saying these medicines are not proven to be effective yet in this population, and they're not necessarily totally benign as well. So to quote our president, we don't want the cure to be worse than the problem itself. And so what is the association between these drugs and arrhythmias? Well, we've already started to see people trying to treat themselves with some of the antimalarials and having tragic results, including a patient who had a sudden cardiac death by self-prescribing a chloroquine product. So I think we really need to find better data and really look at the safety of these drugs in this population. So getting to the mechanism, hydroxychloroquine, chloroquine, lopinavir, ritonavir, they all prolong the QT interval and can potentially increase your risk of torsades de pointes, especially in combination. Remdesivir, imifenivir, favipiravir, some of the other novel antivirals that are not FDA approved, they currently do not have any reports of QT prolongation. Of course, the data is preliminary. We expect these complications to be rare, and we hope them to be rare, but in this pandemic of this scale, we will potentially be having a large number of these patients treated with these, and there's of course 3 million people worldwide who have congenital long QT, and many more who are on other QT prolonging medications such as antibiotics, antifungals, antidepressants, all of which can potentially combine with each other to increase the risk of torsades. I've created a chart here that just kind of summarizes some of the commonly used meds that we're using in our hospital system and elsewhere. How they're dosed and which ones prolong the QT interval. So again, it's mainly azithromycin, hydroxychloroquine, chloroquine, lopinavir, ritonavir. There have been many published reports of both azithromycin and the antimalarials causing or at least contributing to ventricular arrhythmias or sudden cardiac death. While lopinavir, ritonavir does increase the QT interval, there aren't specific published reports of them by themselves leading to cardiac arrhythmias. Azithromycin is well publicized that it does lead to an excess in cardiac deaths, famously published in the New England Journal almost 10 years ago with about a million prescriptions comparing azithromycin and amoxicillin, found a significant increase in both excess deaths and sudden cardiac death. So these medications, I repeat, are not benign, especially when they're not proven to be necessarily effective yet for COVID. In the labeling for azithromycin, they specifically refer to one of their studies in their warning, noting pretty significant QT prolongation when it was combined with chloroquine, and that's a similar combination to what we're seeing being used in our patients now. There are many drug-drug interactions in addition. So here I've made a table listing the medicines that we're currently using, and many of their cardiac drug interactions. I've highlighted many of the cardiac drugs. I've highlighted in red the ones that have really significant interactions, and that combination should potentially be avoided or really strictly monitored. This includes many of our antiarrhythmics and many of our DOACs, we will hopefully be putting some of this together as a resource that'll be more widely available, and we'll hopefully work with our pharmacy colleagues to make sure we are treating our patients as safely as possible. Dave Shim, Peter Zimmerbaum, and others of us have been putting together an algorithm to try to help safely monitor the QT intervals and make clinical decisions based on that, or at least partially based on that, to help our patients. And we hopefully plan to distribute this widely to our non-cardiology colleagues. But to kind of distill this algorithm, if the medication is indicated, really should be getting an EKG beforehand, ensuring the QT is less than 500, including ensuring that their electrolytes are well repleted, minimizing other QT prolonging medications. And if the QT is above 500, or if it increases alternative therapies. Of trying to probably reason using think I've frozen here. Oops. Let me just go back to find my slides. So I'm just going to wrap up here over the last couple of minutes here talking about treatment. So in general, I think the goal of treating these patients should be to minimize our exposure and contamination of these patients and being mindful of drug interactions while maintaining our standard of care for these patients and treating these arrhythmias. Overall, it's going to be very similar to treating any other critically ill patient with these arrhythmias. So I'm not going to dwell on the specific mechanisms, but I think we should really give consideration when there's equipoise towards chemical cardioversion, for example, for atrial fibrillation with amiodarone, propanamide, or butylide, for treatment of torsades de pointe, considering overdrive pacing with isopril rather than temporary pacing wires. And an important point is if patients are having new ventricular arrhythmias and are pericoding or coding, to pause and make sure you're appropriately protecting yourself by putting on proper PPE and making sure you're safe and not exposing yourself. And to wrap up here, I will just conclude by saying arrhythmias are being reported. We don't know whether COVID is directly responsible or whether it's the underlying critical illness. The mechanisms are numerous, could be directly from the cardiac injury, myocarditis, or just their critical illness. Off-label drugs that are being used do not have necessarily proven benefit in these patients, but do have potential harm. And we should be treating our patients with arrhythmias similarly to our other patients while trying to minimize our exposure and drug-drug interactions. So with that, I will move on to Mark, who will be talking to us about myocardial ischemia.
Ow! Sorry. Oh.
Breakfast ready. You want to have it?
What's she sad about?
Thanks. Sounds like I guess I'm unmuted now. Thanks so much. I'm just going to try to gain control of the slides here. Not able to advance my slides. Sorry for the technical difficulty. So
This is Arthi. Coco, do you want to take back the mouse control and then give it back to Mark and see if that works?
is that working?
Mark, I can just advance them for you. It doesn't seem to be working.
Okay. All right, so go ahead and go to the next slide. Thanks, Coco. So I'm briefly going to touch on some stuff about myocardial injury, although I'll go through this a little bit quicker since we are short on time. I want to get to some questions that I know that are coming in. So I really want to focus more on the STEMI care in patients with COVID-19 and patients with suspected COVID-19. Go ahead and go to the next slide, Coco. So we know that, as has been presented already, there is a proportion of patients with COVID-19, even if their presenting syndrome is more of a respiratory syndrome, that have evidence of myocardial injury in the form of abnormal troponin. In case series from China, that has been as many as 12%. Go ahead and go next slide, Coco. And this is also predictive of mortality. This is in a retrospective cohort study also from the experience in China, the red being non-survivors and the blue being survivors in patients with COVID-19, showing that non-survivors have a significantly elevated troponin compared to survivors. Next slide. So there are a couple of different mechanisms. Coco, you can just go next slide here to show all three here. So in addition to epicardial occlusion, which of course can still occur even in the context of COVID-19 infection, there are other mechanisms that have already been touched on by Anu and others about cytokine storm, viral myocarditis, as well as a kind of an emerging concept of diffuse microvascular thrombosis. Next. So this is just showing similarly red being non-survivors and blue being survivors, various markers. And IL-6, which we know is associated with inflammation, is significantly elevated in non-survivors, as is ferritin. And interestingly, the lymphocyte count is inversely associated. If you have a lower lymphocyte count, you're more likely to be a non-survivor. Next. We also know from Anu that there are syndromes of viral myocarditis, and sometimes this is the presenting symptoms, and it's not an upper respiratory or lower respiratory infection, and this has been evidenced by MRI findings and EKG findings, MRI findings showing LGE and myocardial edema. Next. This is a concept that has kind of emerged a little bit, although there's very little data on this, of diffuse microvascular thrombosis occurring in patients, particularly with severe COVID-19 disease. And part of this comes from the idea that we know ACE2 is the way that this virus enters cells, and there is a certain expression pattern in tissues that has some high-level expression in intramyocardial endothelium, pneumocytes, intestinal epithelium, and renal tubules, all organ systems that are known to be affected. Next. And from the experience in China, this is from Bin Cao, who's the president-elect of the Chinese Society for Respiratory Medicine, has described clots in the small vessels of all organs, not just the lungs, but also the heart, the liver, and the kidney. He's gone so far as to recommend anticoagulation therapy for severe disease anyway, patients with COVID-19 unless otherwise contraindicated. This has not been echoed elsewhere in the literature. The data for this is really still emerging. This is not supported by other guidelines. Next. And the only autopsy study that is available currently in COVID-19 patients, this is from a patient who died from a respiratory illness, but did have biopsies of various organ systems. The myocardial biopsy was fairly bland. It's unknown whether this patient had elevated troponin or other evidence of myocardial injury, but certainly on autopsy, the myocardial specimen was fairly bland. Next. So we'll pivot a little bit and talk about the STEMI care in the COVID-19 era because things have changed a little bit. Next. So we do know that COVID-19 can mimic STEMI in terms of ST elevations on ECG, but we also know that patients will still have epicardial occlusion at some point. And this is from a colleague of mine at Dartmouth. Dartmouth has actually adopted a lysis-first strategy for all patients with STEMI, in part because of the COVID-19 epidemic. But what we see here is this patient failed thrombolytics, had COVID-19. They were given thrombolytics up front, didn't improve, ST elevation didn't improve, so they were brought to the lab and found this circumflex occlusion. Next. So this is a different patient. This is from Twitter, and this is kind of a scary looking EKG with really diffuse ST elevations, but prominently anterior ST elevations with Q waves. Next. This patient was brought to the cath lab, but not found to have no obstructive coronary disease and an EF of 40%. So presumably one of those other mechanisms of injury. Next. Another example of ST elevation. This patient was brought to the lab. Next. And this is not a patient that had a known COVID-19 status. I think this is kind of frightening for all of us in the cath lab. They had no respiratory symptoms. This was the first manifestation of their disease. They had no obstructive coronary disease, developed cardiogenic shock, required mechanical support, and then subsequently found to be COVID-19 positive. Next. Just another example of kind of angry-looking ECG, but really diffuse ST elevation. This person was brought to the cath lab as well. Next. And had no obstructive coronary disease and EF of 20%, and then again, subsequently found to be COVID-19 positive. Next. This is a proposed algorithm out of Oceaner Health in New Orleans for how to manage STEMI patients in the COVID-19 era. And this is anecdotally, I've seen that similar type of algorithm adopted all over the place, which is really a lysis first strategy for all STEMI patients now, not just ones that have a known COVID-19 status, but you can see that since everyone is now presumed infectious until they have a negative test, that's almost everybody who's coming in with ST elevations. They at least try to confirm the diagnosis with a focused echo to look at wall motion. And if their findings are consistent with epicardial occlusion, they'll go ahead and give lytics. Next. So there are a couple of different arguments about how to manage these patients. And one is that we should really be deferring patients with COVID-19 and ST elevation who have a known status or a highly suspected status. We know that this can expose the cath lab. The experience at Dartmouth is one of the patients there who had an unknown status, led to exposures among the cath lab, and about a third of their cath lab staff is now being sequestered in quarantine, which is challenging because it's a critical labor pool. These are the people that put patients on ECMO, deal with true STEMIs, and do other life-saving treatments. Next. The argument that some make is that you can still get rescue PCI if thrombolytics fail. Maybe we should be giving thrombolytics up front, and then the pharmacoinvasive strategy is well described in rural areas that don't have ready access to a cath lab at baseline. And others argue that maybe this isn't such a deviation from our current standard of care in the U.S. at baseline. 20 to 30% of STEMIs get thrombolytics as their primary treatment. Next. We also know that, as I've just shown, ST elevation may not be due to epicardial thrombotic occlusion. Maybe we shouldn't be so focused on getting these patients to the cath lab immediately before the diagnosis can be a little bit more certain. Next. Others argue that thrombolytics up front are not really a prudent option in all patients. And we know that PCI is superior to thrombolysis. There's a decrease in mortality, decrease in the rate of reinfarction, and a decrease in the rate of stroke. Next. And I think really importantly, giving a patient thrombolytics, they have a 1% risk of developing intracranial hemorrhage, which is obviously not trivial. Next. Patients may still need to go for PCI if thrombolysis fails. So this is not necessarily sparing the cath lab staff from exposure. Next. And clearly, it's not a good idea. It doesn't improve. This is really just a therapeutic modality. It doesn't improve the diagnostic accuracy. A strategy of giving thrombolytics doesn't help if the patient doesn't have an epicardial obstruction to begin with, and it's really one of those other mechanisms of injury. Next. I think we can just skip this slide, Coco, but this is the experience from Hong Kong. And one more next. And just showing that door-to-balloon times have substantially increased, mostly driven by patients presenting a lot later. On the chart on the right there, we have symptoms of first medical contact in the pre-COVID area compared to the post-COVID area. And patients are presenting quite a bit later, probably because they're afraid of going to the hospital. Next. This is a conceptual diagram from Greg Stone and others looking at the shape of the curve in terms of mortality reduction on the y-axis and the time from symptom onset on the x-axis, showing that there is kind of a steep part of the curve just demonstrating that there's a real importance of the first 2 to 4 hours after symptom onset. And after that, the slope really changes to be a much flatter slope, meaning that more time doesn't decrease mortality by that much. Next. There's been some guidance from various societies about this, but basically supporting that we need to balance staff exposure and patient benefit in coming to the cath lab. They can consider fibrinolysis, really emphasizing that we should be using full PPE, including N95s, particularly in STEMI patients, even if they don't have aerosolizing procedures up front. We know that they might need intubation during a procedure, or they might need CPR, in which case you wouldn't want to have to put on an N95 post hoc. They also say that while STEMI patients maybe can wait, and we shouldn't be bringing those patients immediately to the cath lab, they also say that if they do come to the cath lab, may facilitate earlier discharge from the hospital, which can be helpful. Next. This is our STEMI management algorithm developed by the cath lab leadership for known or suspected COVID-19 patients. I'm not going to go into in too much detail here so we can get to questions, but I think it does a really good job of kind of dichotomizing patients with known or suspected COVID-19 into those who may benefit from coming to the cath lab and those who the benefit is a little bit less certain. If you have a really severe pneumonia and maybe you have an inferior MI, maybe those patients don't need to come to the cath lab urgently, and we have time to either confirm the diagnosis or continue to treat their perhaps more serious respiratory illness. And this determination is really going to be made by the attending MD. I can go next slide. There has been a whole protocol developed by the cath lab leadership about how to deal with these patients, and really emphasizing PPE and control of the exposure. We're actually going to have a PPE timeout that is separate from the standard site and procedure timeout that we always perform. It really has a good emphasis on minimizing exposure and the cleaning phase. Next. So just some learning points. I know we're really a little bit over on time. Hopefully we can get to some good questions. Elevated troponin is a poor prognostic marker. COVID-19 induced myocardial injury can result from things that are not epicardial coronary obstruction, but also can be epicardial coronary obstruction. And we do know that ECG is a mimicker, although I got a message from Dr. Zimmetbaum that my first ECG clearly showed pericarditis. So there's that as well. Several cath labs have moved to a thrombolytics first strategy, but this carries a 1% risk of intracranial hemorrhage. And as I mentioned before, using thrombolytics doesn't improve your diagnostic accuracy for caring for these patients. So at this point, we can, I think, go to questions.
All right, so a huge thank you to Coco, Anu, Tim, and Mark for having prepared this very well thought out presentation on very short notice. I also wanted to mention and to thank everyone for their patience with our technical difficulties. I'm sorry we're running a little bit late, but hopefully folks can stick around for a few more minutes for questions. We will also be sending out an email for attendance after this presentation. We've recorded the presentation. Hopefully it'll be in a state where we can send out a link, but if not, we will certainly share the slides. So we have several questions that have come out on the chat. Mark, many of these are related to your presentation, and so we'll start with a question from Dr. Bay. Will BI be getting the high sensitivity troponin assay? And I'll wrap that in with a couple of questions about COVID positive STEMI patients, whether they're actually coming in with chest pain and how many of these STEMI and shock patients are actually cases of myopericarditis.
Thanks, Arti. So to my knowledge, we are not planning on getting the high sensitivity troponin assay anytime soon. There had been some consideration before, but I haven't heard about that coming down the pike.
You know what, this is Dwayne. Actually, what we need is not a more sensitive marker to detect myocardial injury, because it's so prevalent in this population and is non-specific. What we need is something to differentiate between somebody that has a type 2 infarction or myocarditis and somebody that actually really is having an acute coronary syndrome. So, I think one of the lessons that Mark said is that actually this is just introducing another factor for us to consider that leads to an assessment of our system and the need for delay. But for the most part, it's just normal STEMI and non-STEMI management.
Thank you, Dwayne. If anyone else would like to come off mute and ask questions, please feel free to do so. We have one more question. I think this is from Hector, or perhaps directed to Hector. Where are we standing on Abbott 15-minute testing before we go to the lab for presumed STEMIs?
Any role in general of using prophylactic heparin?
I think we don't know
Dr.
the answer.
Dr. Gabay, this has come up in the management more routinely, not routinely, of the regular patients who are hypoxemia, and the findings on CAT scan that there's a lot of microvascular clot noted and peripheral clot noted on the CAT scans. We don't know whether this is making a difference in myocardial infarction. But people are anticoagulating these patients, and some are stratifying based on what the D-dimer is, but this is all just kind of made up.
Thanks a lot.
So to follow up on a previous question, does anyone know if we will be having access to the Abbott 15-minute test anytime soon?
The last call from the leadership was that they're working at this is Kazi, looking for other tests, but they suspect that these tests are going to have substantial demand nationally. And so as we compete for stocks, these are probably going to go to the high burden areas first. So they're looking at those tests, but there's no immediate plan to get them.
Thank you, Kazi. Another question that came in from Warren. Are there any data on survival to functional status and discharge for COVID-19 patients who have a cardiac arrest? I'm not aware of any such data. Any of our speakers come across that?
No, I looked for that, and I could not find any information about even the mechanisms of cardiac arrests, let alone their outcomes.
Can I ask a question of the cath lab folks? This is Kazi. Given that we have a pretty long turnaround time for our COVID tests, and that even now a lot of our patients who are suspected COVID are eventually negative, the thrombolytic first approach terrifies me, because we're going to end up thrombolizing a lot of COVID negative people or people with pericarditis. But it's easy for me to say I'm not in the cath lab. I'm not going to be the one exposed when this happens. Can folks who, Mark, what's our thinking on this thrombolytic first approach, especially over the next, we're going to be in this phase for the next 4 or 5 months, and doesn't seem sustainable to me.
Yeah, thanks, Kazi. I think, and I certainly want to get Dwayne's input as well, but I think it frightens me too, and it's kind of surprising to see this being developed so widely as an approach, because, as I mentioned, a thrombolytic strategy doesn't improve the diagnostic accuracy of the ECG and subjects people to a 1% chance of having intracranial hemorrhage, which is obviously not trivial. But I think that, maybe our threshold has to be a little bit higher in these patients with ST elevation and COVID taken to the cath lab than it was before, because our diagnostic accuracy of ECG is diminished. And, I think we might just have to take a little bit more time and not be so focused on the door to balloon time emphasis, which has previously, certainly been emphasized in the pre-COVID era. And actually, interestingly, we got an email this morning about the regulatory stuff in terms of door to balloon time should not be a concern. There's a specific code to show that there's patient-centered reason for delay in PCI, and this won't count in sort of the door to balloon stuff. But aside from that, I think we'll have to be allowed to take a little bit more time to, based on our clinical impression, whether that's, focused echo or serial examinations or serial biomarkers, and really kind of being a little bit more certain that it is truly an epicardial obstruction that is the patient's main problem right then, that could be improved by taking to the cath lab. Dwayne, you probably have some other thoughts as well.
Yeah, I'm with you guys that, you know, a lytic first strategy is really just kicking the can down the curb. You know, as you mentioned, most of these people are going to end up in the cath lab anyways. It's not really about, I mean, we need to protect our staff in the cath lab. And whenever we do a procedure now, and, you know, Anne-Marie has rightfully brought this up, that, you know, basically everybody at this point is a suspected COVID patient, and we're just trying to focus on maybe the highest risk patients who haven't been screened, who are the STEMI and out of hospital cardiac arrest patients. But the decision-making remains the same as it was before COVID. If someone's dying of some other illness besides their STEMI, maybe they're not, maybe they're not, you know, an optimal candidate for myocardial salvage, especially if they're presenting late. And if somebody is a candidate for reperfusion, then I think we need to safely and expertly provide them with what we can give as the best reperfusion therapy. Now that situation may change. The places that are appropriately engaging a lytic strategy are the ones where their system has decompensated. The cath labs have been closed except for one because they've been turned into ICUs. The doctors and nurses have been repurposed, and that's situational. So right now, I don't think that we need to pursue a lytic strategy, but if everything changes, then and there's going to be a delay to reperfusion, then some of these patients may need to receive it.
Thank you, Dwayne. We have a couple of other questions that have come in. I'll combine questions from Dr. Schulman and Manning regarding other diagnostic modalities. Would coronary CTA be helpful in this setting, or is there a role of POCUS, point of care ultrasound, to discriminate regional from global dysfunction, with the caveat that some myocarditis may still be regional? So we'll go with those.
These are good, really good questions. I've seen other protocols that have involved coronary CTA. I don't think we really have that sort of 24/7 availability, and also it doesn't solve the problem of exposing, a whole area in, the CT scanner that's not a negative pressure room and would have to be terminally cleaned and all this kind of thing. Additionally, a lot of these patients are really tachycardic, and that limits the diagnostic quality and accuracy of a coronary CT. I do think that there's probably a role for focused echo, just looking for regional wall motion abnormalities, acknowledging, I think as Warren has said in the chat there, that there could be regional myocarditis, but just some incremental increase in our diagnostic suspicion that this is due to a thrombotic epicardial occlusion. If you can do that with a focused echo, I think that is really helpful.
Thank you, Mark. Another practical question from Dr. Bay. Are there any differences to the cath lab workflow, for example, over the weekend, for inpatients that come in with ACS that do roll out for COVID and need a cath? So are those patients, if necessary, being done over the weekend, or are they typically postponed until the week?
Dwayne, do you want to speak to that? I think that has exactly been what's been thought about being enacted.
Yeah, so, for about a week or so now and into this weekend, we've been trying to expedite patients' discharges, to make resources available to the COVID patients, but also to decrease the time of exposure of the patients in the hospital. So patients that would normally wait over the weekend for a cath on Monday, or wait for a CT surgery consult or an angiogram are getting done over the weekend. This is going to change too, likely, because as nurses are repurposed, we're hearing that the possibility of about half of our cath lab nurses are going to be repurposed. We may not be able to offer that, and we'll just have to kind of make some decisions as they happen. We're going to have, nurses and physicians that are on call for 24, 36 hours at a time, and it may not be easy to accomplish.
Thank you. One more question from Vlad. Have people been actively trying to minimize contrast exposure, given some reports of increased renal injury in COVID?
I think we always try to minimize contrast exposure as much as possible, and this is no different than that.
Okay, so in the interest of time, we'll wrap up. There are a number of other interesting comments and discussion on the chat feature. A huge thank you again to all of our speakers and for our participants for a really great discussion. We'll follow up with emails and hopefully be able to include a link to this lecture afterwards. Thanks so much.
Marty?
Yes.
This is Al. Can I just say one thing about arrhythmia management in these people?
Sure.
First of all, I would urge anybody that's taking care of these patients to first try and obtain good quality and safe EKGs so we can characterize the arrhythmias that are occurring and to determine the relationship to the viral infection or other conditions. Second of all, because of the concern about QT interval, for people that develop ventricular arrhythmias that do require treatment, think about using lidocaine as a first-line therapy intravenously, since it has the lowest possibility of prolonging the QT interval. It's not zero, but it's very low. And another alternative to think about for managing arrhythmias, if lidocaine doesn't work, or conceivably in adjunct, especially in people that are getting other drugs that may prolong QT interval, is dilantin, which also may act beneficially in this situation. That's all.
Thank you, Al, for those observations. So we'll see everyone next week. We will be doing grand rounds virtually. Next week, we'll have Dr. Binny Shah speaking from the Brigham and Women's Hospital. So we'll see everyone then. Thanks.